All right, thanks for joining today. We have the honor of talking with Dr. Sean Murphy, who is an ER physician of a community hospital in Tucson, Arizona. And today he's going to kind of walk through what he's been seeing in the ER, some of his concerns about these new GLP-1 drugs like Ozempic, and share some thoughts on, should you take them, should you not, or at least just share some side effects that you might not be seeing on commercials, for example. So, Sean, take it away.
Sure. Well, first of all, the honor is all mine. Thank you for having me for this discussion. Yeah, I would say to start off with, I'm an emergency physician, as you mentioned, so I've never prescribed Ozempic before or any of the GLP-1 inhibitors. My job has always been on the receiving end of the complications, so of course there is that perspective to be noted coming from me, but I think one thing that's important to emphasize is that whenever a doctor prescribes you any medication, take careful note of exactly what they tell you about the risks, benefits, and alternatives, because I do think that, unfortunately, these discussions don't often take place with any detail or depth or feature data to actually give you an idea of the probability of certain things occurring. Now, that is a generalization. I'm sure there's lots of excellent doctors out there who do a very thorough job. And admittedly, there are also doctors who, well, they're terrible. There's terrible doctors too.
Right. I think we should also say, like, this is the system we've created for healthcare in the US. Doctors get a very limited amount of time with patients. So, and they have to cover a lot of ground during those visits. Is that correct?
Yes, and admittedly, I mean, some of my best friends do primary care, and they often lament to me about the pressure on them for turnover and how quickly they're supposed to address, especially in a primary care setting, every single one of the patient's problems, all their chronic medical issues, whatever the acute issue is that they want to address today, and they're being recorded and tracked with metrics like, did you address X, Y, and Z by CMS? So they're under a lot of pressure. So oftentimes that is a problem in that setting. Weight loss doctors, I think similarly, they're trying to drive volume. I mean, for whatever the motivation is. So all doctors are under pressure. Obviously, in the ER, I'm under a lot of pressure, to quickly triage and get on to the next patient, so I'm not missing the patient who has a serious life-threatening emergency. So we're all under pressure, that's true. But I think when it comes to committing someone to a medication they're going to take for the long term, making that discussion particularly abbreviated is crossing an ethical boundary. Now, for some doctors, that it's worth it. But personally, I think especially with medications like this, who I've been seeing these side effects in the emergency room, there should be a concrete and heartfelt discussion about what this really means, what are the alternatives, and what can I expect to see in terms of complications at what rate.
Yeah, I want to circle back to, what you're seeing in the ER. Obviously, that's kind of like the meat of this conversation. However, for somebody who, this is a newer drug, right? Newish, like in the past decade. So can you kind of explain what a GLP-1 agonist is and why someone would want to shell out $1,000 to take it? So like, what are some of the reasons that people are taking it to begin with? And then let's kind of go into the side effects.
So GLP-1 inhibitors essentially were a treatment for diabetes. So they have a number of effects that are supposed to help with the symptoms of diabetes, controlling blood sugar, reducing appetite, and importantly, the complication, the effect that leads to complications is slowed gastric emptying. So now one of the side effects, you could say a side effect, essentially what it was that patients lost weight who had diabetes, who took GLP-1 inhibitors when they were prescribed for that reason. And obviously, cha-ching, people got some great ideas. Why don't we give this to people who aren't diabetic to see if we can get them to lose weight? And it's it's unfortunately a trend in medicine that we like to do things that don't require conscious effort or change in our root cause illness or our lifestyle, and it's very easy just to inject something or take a pill. So this has become extremely popular, obviously. Now, as to all the hormonal effects, I mean, there are numerous effects that the GLP-1 inhibitors have on the body, on different organ systems, from the brain to the intestines to the pancreas. So there's myriad effects, but bottom line is that the idea is that they're originally developed for diabetes and now they're used for weight loss. So that's the theory behind it.
Delays gastric emptying, so you feel full for longer, so you tend to eat less, right? So you have that feeling of satiety, so you're eating less, and that makes sense. Like you're going to lose weight with that.
Yeah, exactly. Yeah, so you just imagine when you're eating, your stomach is the initial processor of your meal, and if that's filling up quickly because it's not emptying, then yeah, you're just going to eat less, which in general, I think as a weight loss strategy, just eating less, I would never recommend patients do that. Usually it's about eating differently than eating less, which unfortunately that was a big movement for a long time, which has been abysmal in terms of efficacy. Eat less, move more. I don't think it's been effective, but so the idea is, yeah, just get people to eat less by having the stomach empty less. So that's exactly what it does to the stomach, and that's intended. But what I'm seeing in the ER is that this can be severe, and to the point where patients can't actually empty their stomach at all for a period of time, and that can even last for weeks at a time. So
what will that look like? Like what symptoms would a patient feel that would send them to the ER?
So in truth, in the package label, they do say that 1 in 4 patients will experience nausea with the GLP-1 inhibitors. So that should be noted for anyone who wants to try it or is trying it, that 1 in 4 will get nauseated. Now, what we see on the far end of the spectrum of that in the ER are patients who actually can't keep any food or water down. Their stomach is so paralyzed. Again, gastro just means stomach. Paresis means paralyzed. So paralyzed stomach. It's the exact translation from the fancy jargon. So you have a paralyzed stomach. Your stomach produces about 2 liters of gastric juice a day that is used to digest your food and then is reabsorbed in the intestines. So you have your food, you have all this gastric juice, the stomach can't empty it all. That has to go somewhere, and people end up with just absolutely severe, intractable nausea and vomiting that lasts the entire day, to the point where sometimes they actually need to be admitted to the hospital to receive IV fluids because they can't even keep down water. So this is, I mean, it's just absolutely horrible when it happens. The patients are suffering miserably for the benefit of a modest amount of weight loss, if that's their intended goal. So yeah, that's the main complication I've seen. I've seen that in patients, as young as 21 years old up to diabetic patients who are later in life.
Wow, so uncontrolled vomiting. So when you get a patient like that in the ER, as the ER physician, what do you even do for that? Like, what's the treatment there?
Well, you have to gain IV access, and you're giving usually large and multiple doses of anti-nausea or antiemetic medications, and repeated boluses of IV fluids, saline and lactated ringers, basically fluid to replace electrolytes and fluid that you're not able to consume and that you're vomiting it up and your stomach is making, presumably to help you digest. So we've seen you have to give very high doses of antiemetics to get this particular type of nausea, vomiting under control. And oftentimes you have to do multiple agents, not just a single antiemetic agent. And patients will typically respond to that, but this tends to be something that persists while the medication is still in their system. In particular, recently I treated one patient who was coming back to the ER repeatedly, day after day, and ended up needed to be admitted because they would feel better. They'd get sent home from the ER with prescriptions for nausea medications, but they couldn't keep those down, or they weren't powerful enough, and they just came right back to the ER because they couldn't even drink water.
So when you get folks like this who have the uncontrolled vomiting, are they like, I think this is from Ozempic, or is it like a conversation you have to have with them? And I'm sorry, I shouldn't say Ozempic because that's just one of the GLP-1 drugs.
That's typically the one that they're on, that I'm seeing. Yeah.
Yeah, or is that something you have to uncover and like have a conversation with them about, like, hey, we think this is from this. This is what we've been seeing.
Well, I'll say my experience has been patients look at Ozempic very favorably, and they're very hopeful this is going to make a huge difference in their lives. So I have seen reluctance to believe that this is due to Ozempic because they, the hope and the wish that this is going to make a big difference in their lives and make them lose weight and help their diabetes get under control. So, without having to make any other changes to their life, unfortunately, obviously, there are some patients that do use these medications in combination with important lifestyle changes, but I do see a lot of patients who they're eating the same food, their lifestyle is the same. They're also taking this, so they're very reluctant to believe that this is due to the Ozempic or the other GLP-1 inhibitor. But yeah, sometimes I actually have to pull up, the package insert and say, hey, there's no test to say, yep, this is definitely due to Ozempic, but I don't see what else this could be. Now, I should also say one of the complications of diabetes, obviously, is nerve damage throughout your body. So diabetics can get a condition called gastroparesis because of damage to the nerves in their stomach. So it's actually contraindicated, or it's strongly advised against if you have a diabetic patient who already has some degree of gastroparesis from the nerve damage, having diabetes for some time. They should never get Ozempic because, or GLP-1 inhibitors, because that will just make that condition 10 times worse. That's something important to keep in mind.
I was reading some of the, warnings on the drug makers' websites, and yeah, that was very clear. But again, like, how many patients are actually going to the drug website? Like, I think they expect their physician to have that conversation with them. And some other scary things like long-term data that we don't really know about. And it's very clear on the drug makers' websites. Like, if you have a family history of thyroid cancer, like, do not take this drug, right? It is known to cause thyroid tumors in mice. And are mice humans? No, but we don't have the long-term data on humans. And it's going to take conversations like this to talk about like the short-term side effects. And we don't know the long-term side effects right now. So I think that's scary in itself. Anytime there's a new drug on the market that doesn't have long-term data, I'd be really hesitant to take it, especially if it was $1,000 or more a month. It's a lot of money. Are you seeing anything else that is concerning you in the ER lately, now that this drug is so widely prescribed?
Well, technically, this drug, if it's being used for weight loss, really should be used for someone who's very overweight or obese. But I'm seeing college students coming in who, technically they may be slightly overweight, but and unfortunately, it's also women who they just want to look better on GLP-1 inhibitors. This is, I truly think this is kind of crazy.
I can get into what I've been seeing clinically later on, but is there anything else that you want to add that like you're like, gosh, like, is this from this new drug, or is it really hard to tease out as it's still pretty early on?
So as far as the side effects go, personally, I think that when the side effects get to the severity that the patient is coming to the emergency room, it's pretty clear to me. There's simply no reason a 21-year-old female should be having, just horrific, intractable nausea and vomiting when, you check everything else. They're not pregnant. There's no pancreatitis. Their other laboratory studies are normal. It's not a gastrointestinal infection or a GI bug. it's pretty clear that this is from the GLP-1 inhibitors. So generally that can be sussed out. But yeah, as far as what to do, other than tell them, I really advise you not to do this. Some people take it and it's totally fine. I mean, some people take it for years and they have no side effects or minimal side effects. So that's fine too. If it works for you, that's fine. I just important to be aware that it doesn't work for everyone. And before you start it, you should take that into consideration and know when to stop it. And if you do get these side effects, you absolutely should stop it and try a different strategy.
Yeah, absolutely. And then the different strategy, I think that that's the tough part. And a lot of healthcare providers simply, they don't have the skill set, the knowledge or the skills to discuss nutrition with their patients. In Chicago, which has a decent reputation, we spent 1 hour talking about nutrition. And the gist of it was refer your patients to a dietitian. Meanwhile, my patients now who speak with dietitians are given Ensure, Boost, told to follow the food pyramid, like really antiquated information. So it's tough. How many hours of nutrition did you have in medical school? I'm curious. I think the studies show average 17 hours, which I think is a little bit high. Most real people I talk to, they're like, oh no, it's probably more like 8, 9, something like that. What was your experience where you went?
Honestly, I mean, there's no way I could quantify it. It was minimal, yeah, something in the single digits number of hours. But it's been a journey for me learning about this topic. And I'll just say, whatever education I did get, and this might sound a little harsh, but I truly believe it. It was amounted really to, unfortunately, what is basically marketing for high margin industries, agribusiness, and these processed foods like you just described. Ensure. I mean, this stuff is absolutely terrible, and unfortunately, yeah, the education is backed essentially by a gigantic movement, which includes things like the food pyramid, which obviously in scientific and medical history is a pretty recent phenomenon, but it's really a marketing pyramid.
Right.
It's a marketing tool for industries that are able to capture research and medical bodies to get them to back them. I was just at the store the other day and I saw chocolate Cheerios were on display in a huge pyramid with a big label on them saying, "Will lower your cholesterol," indicating that maybe this is a healthy food, which is just an example of how it's understandable people get confused by the messaging when physicians are taught, we need to recommend that the base of your diet should be processed grains. And that's really good because here's a study that shows it can lower your cholesterol. Does that translate to any health benefit? What about the risk of diabetes? And these are just questions that kind of get swept under the table because, well, we have other treatments for diabetes. We have treatment for cholesterol. So just, basically go along with this antiquated dietary information, which is essentially marketing for the highest margin food products and companies that produce these foods. And then we'll take care of all the complications of those ill-informed recommendations.
Right. And I think a lot of people don't understand that medical schools, dietetic schools are often funded largely by pharmaceutical companies and big food companies. So it's really hard, I think, to get good nutrition education in these programs these days. So it's going to take a lot of figuring it out on your own after these programs to really, change the course of this country. I do want to make a correction. We spent a half day talking about nutrition in school, which I still think is definitely not enough. Not enough to tackle the increasing rates of diabetes, cardiovascular disease, dementia, and the list goes on. Sean, I'd like to just share a couple things that I'm seeing clinically that concerns me. I'm not affluent, but I work and live in a fairly affluent area. So people do have the cash to, shell out $1,000 a month to pay for these drugs. Again, I'm not of that category, but this is the population I'm serving. And some things that I'm seeing are, one, out of all my patients that are on these drugs, I ask them, not in a judgmental way, but like, what was the conversation when you were prescribed this drug? Like, and specifically around nutrition, and not one of them had a conversation with their physician about the importance of protein intake in general, but especially when you're on this drug. And why that's important is, as you know, obviously, and many of our listeners know, one of the side effects of this drug is you have a tendency to lose a lot of lean muscle mass. So good muscle tissue. So a lot of the weight you're losing is not just fat, but it's muscle tissue that you need. What I'm seeing clinically is scary stuff. So, for example, I had a woman recently who, had a trip to the hospital. She had been on this drug for about 4 months. She went in for nausea and a bunch of other symptoms that may or may not have been related to her taking these drugs. But what happened was she got home. So, woman in her 60s, otherwise healthy outside of, dealing with obesity for a few decades. And she got home and she could no longer stand up on her own, right? And that's not okay, right? So talking with her about proper nutrition was really key because she had no idea that while taking this drug, she was going to lose that muscle mass. She had no idea that it was important to eat protein to help, build muscle mass with the strengthening that her and I were doing together. So that was scary. A couple other instances, and of muscle mass loss that's translating to poor function is I treat a lot of elective surgeries, so folks that are getting knee replacements. And what I've been seeing is the folks that are on these drugs, their knees are buckling when they're walking. And knee buckling is all that really means is your quads are very, very weak, their front thigh muscle. Our quads weak, leading into a knee replacement, likely, but they shouldn't be buckling, right? So that is, again, something scary that I'm seeing. And all these patients, again, they're not having conversations with their doctors about, proper nutrition to, supplement this drug. And I think that that's the scary part. So the drugs are expensive. If someone took, let's say, $1,000 a month, what do you think? This is just your personal opinion. What do you think would be a better use of that money to help them lose weight, change their diet, change their lifestyle? What would you do? If you had an unlimited amount of time with a patient, what would you recommend if you had that extra cash around?
Well, I mean, invested in the root cause of both diabetes and excess weight, which is better food. And that, to me, the simple recommendation would be take that $1,000 a month and buy the tastiest, fattiest, most delicious red meat that you can find and you can afford. And if you can afford that, obviously that's a lot of good meat. $1,000 a month can buy you a lot of good red meat. And in the end, what we're trying to do with this drug is promote satiety. And that is exactly what the problem is with both weight gain and diabetes, is a lack of appropriate satiety for what is consumed, which is just a feeling of I've had enough. I'm satiated. I'm full. When you eat nutritious, wholesome, healthy food like red meat, you know when to stop eating, and that nourishes your muscle tissue. That can help you recover after physical therapy, or if you're doing sports or weight training. That it's an absolute superfood in terms of what it offers your body in terms of vitamins, minerals, protein, and healthy fat, and is essentially addressing exactly what you want to be addressing with the GLP-1, but you get to eat it and it's delicious. I mean, personally, I think it's delicious. So I would invest in a high quality red meat, in particular, eggs, satiating food like that.
I think that circles back nicely to your comment of like the old model of weight loss is move more, eat less, and why that has failed for many people. Maybe that's worked for some. Good for you. Keep going. But you're hungry all the time. So it's not sustainable, right? So I think when a drug is offered, like, hey, here's this drug that you can continue to eat whatever the hell you want, and you're still going to feel full and you're going to lose weight. I get why people would take it. All right, so you're promoting, eating real whole foods that, automatically tell your brain and your body that you're full. Yeah, I think that's more the sustainable way. I haven't seen any diet or lifestyle changes in the folks that are taking these drugs. I think that you can take this drug and also make those changes, but it's going to take a lot of willpower. And like most Americans, you're probably already addicted to ultra processed food because it is designed to be addictive, right? If you give me a box of Cheez-Its, I could polish that off in a day. That is a guilty pleasure. I know I can't keep them in the house because I love them. They were designed to be delicious. And I'll be the first to admit that I think they are. But I know I can't have them around because I could easily get addicted. I don't know if you have another example like that or
Well, my treatment for Cheez-Its addiction is cheese wisps. So just little circular, crunchy cheese bits. I mean, you get some of the same texture with, much better nutrition. So that's my go-to prescription when people are struggling with Cheez-Its, dependency.
that's good. Kind of subbing it with something else. That's a good
Yeah,
one.
yeah. I mean, there's a lot of stuff like that, where maybe someone really likes a particular flavor or texture, and there's often something that closely resembles it, but is much more wholesome.
Yeah, absolutely. So you have a unique story. Can we switch gears and talk about how you changed your diet a couple years ago and what prompted you to? Like, what kind of symptoms were you having where you're like, gosh, like maybe this Mediterranean diet that I'm on isn't working for me. And what else could I try to heal my body? So I think you have a really unique story that you've shared with me.
Sure, yeah, absolutely, open book. So I guess, well, my whole life, basically, since I was a child, I struggled with symptoms of autoimmunity, which took a while to formally diagnose. Yeah, when I was a child, I remember the pediatrician telling my parents that I was anemic, but they didn't know why. They would check for nutritional problems like iron deficiency; those were all normal. My parents were very active. They're both athletes. They followed the food pyramid because it was thought, oh, this is great. The scientists have all found the way, and so we ate a pretty healthy, well-rounded diet. But I was anemic. That was the first sign something was wrong. My exercise tolerance wasn't as good as my peers, but they just said it was anemia of chronic inflammation, and they didn't know what to do about it. So then fast forward, when I was in college, playing sports on the rugby team, and started getting horrible joint pain out of nowhere, joint pain and swelling, and sometimes even limiting my ability to move my joints, like my elbow. Finally, I went to a doctor, then a rheumatologist, and they measured autoantibodies, which how you diagnose autoimmune disease, and I was positive for a kind of a rare autoimmune disease called mixed connective tissue disease. So I was started on immune suppressant therapy, and this is one thing with rheumatology is the consensus is that there's no clear cause, with maybe the exception of celiac disease, which we've determined to be caused by gluten ingestion. So that's one. But interestingly, that's a good example of we know that it's possible for food to cause autoimmunity in that case. So would it be a stretch that maybe some other autoimmune diseases could be caused by other things you're eating that are triggering your immune system to thinking that there's an invader or an infection? Interesting case example. So I go to my rheumatologist. They say, look, we don't know. This just happened. It's bad luck. It's environmental, factors of unknown origin, and take immune suppressant therapy. So I was on that for many years. I was on prednisone and hydroxychloroquine. And come one day, I was working on a project with a medical student, a research project, and just out of nowhere, he mentioned something about an all beef diet being used for autoimmunity. And that led me to Sean Baker, which maybe some of your viewers are familiar with, the carnivore diet book author. He's been on Joe Rogan. So read his book, also read some other books on the topic, Paul Saladino and Nina Teicholz, some amazing authors. And it gave me at least a starting point to think, wow, maybe autoimmunity does have a reversible environmental cause. And I thought, what's the downside of trying it? And all these books are pretty compelling about the health benefits of a diet that includes wholesome meat. So I decided I'm just going to go all in, and that was the best decision I've ever made for my health. And I mentioned this before, but I feel bad. I'm 36 years old currently. I feel better now at this point in life than I did my entire life, even when I was a child or a teenager, in terms of my exercise tolerance, my ability to put on muscle and recover from exercise, energy levels. And I have a diet that is essentially exclusively fatty red meat and eggs.
Do you eat anything else besides red meat and eggs?
Butter, and I do drink coffee. I'm an ER doctor after all, so I work
Yeah.
24-hour shifts sometimes, or sometimes overnight shifts. Coffee with cream, and sometimes cheese. So that's essentially what my diet is.
And that makes you feel the best. I know a lot of carnivores will include things like fruit, sauerkraut, kimchi. Do you ever play around with those foods, or are you just like, you know what, I feel awesome on this, so I'm just gonna keep going?
My personal opinion, I don't see any reason to eat vegetables. I really don't think vegetables offer any special nutrients, and often just can basically give you some GI discomfort and gas. Everyone's different, obviously. Some people tolerate them very well, but this is total anathema to what I learned in school. And like you alluded to it, for years I was convinced the Mediterranean diet was what it was all about. Yeah, vegetables and hummus and fish and this kind of thing. And I've never been more ill than when I was on that diet. And that's me personally. I mean, again, this is an individualized thing, but yeah, I really don't see a compelling case for consuming those, when most of the time they're barely digested, and the bioavailable nutrients are pretty low when all is said and done. As far as fruit goes, sometimes I'll eat a little bit of low carb fruit like avocado or olives, just as for flavor variety, mostly because they offer some additional fat and they're delicious. But besides that, nothing else really.
Meeting a lot of people through Twitter X and this space who have a really similar story to you. We're suffering from something, whether it was Parkinson's disease, severe migraines, in your case, some sort of autoimmune dysfunction. And the answer has been to really just simplify their diet. And then they got a lot of other benefits that they weren't expecting, like this mental clarity, like, oh my gosh, the weight comes off. I see my muscles. Whoa, I have muscles under there. So I think it's really fascinating. I think that there's a lot of haters on this diet. And instead of like pointing out like what our concerns are, I really think we should be asking the question, what could this offer, instead of, what are these people at risk for? And I think Sean Baker is such a good voice in this space because he is pretty humble. He's like, we don't know the long term yet, but he's like, my job as a doctor is to make someone healthy right now. And if a diet like this solves not one, but all of their physical problems, maybe this is the solution, right? And maybe we shouldn't be so worried about if the person's going to live to 100, right? I don't know what your thoughts are on that, but I enjoy listening to him because I think he is really humble in this space where, without naming names, a lot of others on the other side are not necessarily that humble and say, this is the answer. Like, this is hard science. Like, there's no, we know it all already. And I think that's silly because that's not how science works.
Yeah, I completely agree with your sentiment. And yeah, Sean Baker is exemplary in that regard. I like his I mean, he's got humor, a sense of humor too, and he likes to have fun with it. But He is very humble, but look at the guy. I mean, he's a tank, you know. I mean,
Right,
he at least proves that, hey, look, you know, I don't eat any carbohydrates, but I look like a bodybuilder, and he's, you know, 57 years old now.
right. And he
You know,
fixed his own health issues, right? I'll put a picture up above so people can see, but I mean, he looks phenomenal and he's
right.
healthy.
Yeah, so it's proof when you look like, you know, guys like Michael Greger, and they, you know, they look sarcopenic and like
I know.
they look ill, and they're, you know, promoting this diet. It's just like that alone is like, you know, it's one data point. You shouldn't entirely base that on appearance, but you know, these are two very different people. Which one do you want to look more like? You know, but I think, you know, it is, there is some social dilemma there, because it is a little bit hard to be a carnivore and exist in society. It's a strange thing. It's not widely accepted. People are very, I mean, I even dated another physician, a dermatologist, who she said, there's no way we can do this because I'm too worried about your cholesterol.
Right, right, right. I think people are still so in fear. This is indoctrinated in us that cholesterol is the boogeyman, the bad guy, and that we should all be, watching out for if we care about our health.
Yeah, and you know, if I can emphasize one thing too to your audience, which I'm sure this comes up at some time, it's, you know, if you just want to get an easy starting point, probably the biggest, most important, if you want to have a boogeyman, and that's helpful, is polyunsaturated fat, omega-6 fat, particularly for autoimmunity. If you're struggling with inflammation and autoimmunity, in the short term, just eliminating omega-6 fat from your diet, or balancing that ratio of omega-6 to omega-3 fat, is probably the most important dietary factor that you could intervene on, which doesn't even require you to become a carnivore. It just means you need to start checking what are your sources of fat, and eliminating those processed seed oils, vegetable oils, and replacing them with healthier fats and omega-3 fat. That alone would make a huge difference for autoimmunity and diabetes, and just a myriad other conditions, including heart disease, etc.
Yeah, so just so people know what you mean by the polyunsaturated fats. So those are things, the omega-6 oils that are touted even by the American Heart Association today. I was reading an article by them. They're still saying, for example, use canola oil, vegetable oil on your eggs, but also limit eggs to, no more than one a day. So those are the oils we need to stay away from. And really, we probably should stay away from most of the recommendations by an organization like the American Heart Association that's still operating out of an outdated manual. So, and really, like, I think that if you're avoiding those oils, like you're not buying them for cooking, but really the natural habitat of a canola oil is ultra processed food. So if you're sticking to real whole foods, it's really an easy thing to stay away from. Are you
Yes.
going to encounter it when you go out into a restaurant? Of course, but if you're going to live your life and still be social, having a meal like that once in a while isn't going to kill you. Or, you just eat before and still go enjoy the company of your peers. So there's a lot of ways to avoid them in this day and age. So I really like that advice. Yeah.
That as far as, you know, like you said, if you're going to have a boogeyman, you want to have one thing to focus on. That's probably the most high yield, in my opinion.
Yeah. And there's a lot of defenders of these oils. Like anytime I mention them on Twitter, people come after me. It's like, okay, why would I want this highly processed, cheap oil in my body when other forms of fat that taste good and make me feel good exist, right? And it's not like canola oil is like that much cheaper than, superior forms of fat like butter, or I like olive oil still, or, whatever high quality fat that you want. The price difference isn't that much. So just make the switch. Just make the switch. Yeah, I noticed that when I go out to eat, I definitely suffer from some GI symptoms, and and I typically stay away from gluten, so I don't think it's that, and I really do think it is these oils. So maybe I'm crazy, but I just feel better with the home cooking where I can control the source of fat that's going in my food.
Not
Anything
great.
else you want to add, Dr. Murphy?
No, I just want to say, keep up the amazing work. I'm really inspired by what you're doing, and we had a conversation yesterday, and you noted that, this is going to take a grassroots, ground up movement. And I think that I'm proud of what you're doing, and to your listeners, I'm proud of you listening and having an open mind to this. And one thing I'd like to stress and emphasize to anyone willing to listen is, don't forget that you are a part of science, and your observations matter. And if someone tells you that something is, the science is over with, we've concluded that this is the way it is, this is the truth, that your observations, what you notice about your body, how you feel, that matters, and that's truthful. That's truth. So your own observations, how you feel, and gathering that data that's also part of science. And so you can be a part of that by doing your own experiment yourself, getting yourself feeling better, and trust those observations, and trust when you're losing weight, gaining muscle, feeling better. If people are telling you this is unhealthy, it's going to cause you to have a heart attack or a stroke because you're eating too much, whatever it is, cholesterol. Obviously, you can always gather data and listen to people's opinions, but trust how you feel, and don't forget that you have the ability to determine what's true as well.
Absolutely, I like that. And I think to any healthcare providers listening, in addition to that, just let's start listening to our patients more. I think I really saw a shift in my practice when I started talking less and listening more, especially to what was working for patients, or why they would take Ozempic, right? Like, because that's how we learn. And I think for to wrap up this Ozempic conversation is a lot of people just didn't know what to eat. They're hearing conflicting messages from their doctors. One is a plant-based, one is telling them to eat Mediterranean diet, one is saying, keep up with oatmeal every day for breakfast. And then you're bombarded with everything in the grocery store. So it's a confusing time. But if we really go back to our roots and just really simplify what we're eating, I think that's a really good place to start. But thank you so much for your time. I hope to hear more of your stories. I'm trying to encourage you to be a little noisier on Twitter, because I think you have, or X, I think you have a lot of insight to share with others. And it might seem everyday stuff to you, but most people don't hear these stories, and we need to talk about them because, again, we're not going to hear them on CNN. We're not going to hear them on NBC, nightly news. So I think we have to hear them from soldiers like yourself who are, in the trenches doing this work, and just start asking different questions. All right. Thanks again for your time, and I hope you have a great rest of your day.
Thank you. Thank you, Lindy. I wish you the same.